Okay. So, a case of child with hypertension, pus cells, RBCs in urine. Again, it's like a same before. He just gave a small history. He did not give previous 1 week there was any history of tonsillitis. So this can be also pyelonephritis or glomerulonephritis. You have to see the whole scenario and decide over. Okay. So the question is a case of child with hypertension, pus cells, RBCs in urine. So it can be pyelonephritis or glomerulonephritis depending upon if there is high grade fever. Hypertension is there but not very high. And
ما في abdominal pain يبين ما كان برضو من الحاجات abdominal pain والفيفر صح؟
in pyelonephritis, right?
Yes.
Yeah.
Yes.
So there's no abdominal pain. So we don't know. Depending upon the whole scenario, either it will be glomerulonephritis or pyelonephritis. Next is normal anion gap acidosis. Where do you see normal anion gap acidosis? It is most likely renal tubular acidosis. So the options here is diabetes mellitus, renal tubular acidosis, nephrotic syndrome, and uremia, and shock. So in diabetes mellitus, what type of acidosis you see?
Metabolic وليس.
Yes, metabolic acidosis, usually.
So here you in renal tubular you see normal anion gap acidosis. Years old presents with 12 years old presents with vomiting, diarrhea, and streaks of blood in stool. Streaks of blood in stool investigation, and he has mild acidosis, increased kidney function tests. What do you want to investigate in urine? So vomiting, diarrhea, streaks of blood in stools, and also there is picture of acidosis and increased kidney function test. That means this is dehydration. So you will investigate for fractional excretion of sodium. Everyone will agree with this?
No idea. What does fractional excretion of sodium does? Because with this
أتوقع يس عنده في سبب بتاع البري ورينال وبوست رينال كوز. فلما تحسب الاكسكريشنز اوف ذا صوديوم بحدد لك هو السبب بتاع الرينال كان بري ولا رينال كوز ولا بوست رينال كوز. ليه يعني الكدني دي فانكشن السبب شو
مع
كان؟
البوست رينال كوز هو الobstruction مش؟
بري يس يعني قصدك كده الأسباب
أيوة.
not remember يعني البري ممكن يكون dehydration gastroenteritis.
Yeah, this is pre-renal. This will be pre-renal here because vomiting, diarrhea will cause dehydration, right?
بس ما هي ما gastroenteritis هنا لأنه في streak of blood in stool maybe infections.
Yeah, maybe dysentery or maybe.
Exactly. First thing that's even coming to my mind is HUS, hemolytic uremic syndrome.
Yes, hemolytic uremic syndrome.
Yeah.
Why are we now checking for functional excretion of sodium? Normally we should just do check all the blood parameters, check the renal function is raised. Then just because stool culture will take a long time before you get dysentery, Shigella, or E. coli, or whatever type of HUS.
No. The question here is in urine, what is the thing you want to check? This is what is the question. Now, this is the picture of gastroenteritis, vomiting, diarrhea, streak of blood in stool. And the child.
البلد ستريكي يعني معناها 1 بلس بس ما كتير صح؟ عشان تقولي dysentery وكده.
Streak means just 1 plus. And mild acidosis. is there, increased kidney function is there. So we will investigate for, does this fractional excretion of sodium will make us differentiate between, as you said, pre-renal, renal, and post-renal?
Yes.
Maybe this is the reason. But we know here the cause is pre-renal because of the GE, vomiting diarrhea.
Yes. بس حتى الديوريشن ما محددة ولا الفريكوان بير داي.
Yeah. Anyways, if you want to investigate urine, you investigate for fractional excretion of sodium. But if let us check other options, specific gravity, I don't think so. Just urinary sodium and urinary osmolarity. That's all is given. We should know what for the fractional excretion of sodium is checked. Okay. I'll just take the picture to check later. And if anyone also checks, can post in the group. Next question. Female child 1 year old.
في سؤال مهم. Why fraction excretion of sodium low in glomerulonephritis expected to be low? Tubes encourage reductions in delivery filter, but could be high if patient has a tubulointestinal involvement, inflammation, or more subacute decline in kidney function. معناها بحدد ليه بري ولا كده؟ لو مثلا كان لقيته لو معناها مثلا كده، لو معناها صحيح بحدد ليه انه رينال ولا برينينال ولا بوست رينال. Are you with me?
Yeah, you're telling if we to check whether the cause is pre-renal, renal, or post-renal, they are checking
Yes.
fraction of sodium.
Indicate if low, indicate renal cause. If high, indicate decrease perfusion due to heart failure, pre-renal. كده. Okay?
Yeah, I got. If in pre-renal, why it will be low? Because the sufficient blood is not going to the kidney.
Yes, maybe high pre-renal والرينال low لأنه الفلتر ما بيحصل له filtrations in the urine عشان كده كله.
1 minute. No, I'm pre-renal, it will be low, right? Because of less perfusion to the kidney. In renal, hello?
Yeah, hello, I can hear you.
Yeah, no problem. We will check later about what are the interpretation of fractional excretion of sodium. Next is female child 1 year old, healthy, presented with high grade fever and irritability. Physical examination within normal except temperature elevation and irritability. Urine sample collected by bag after cleaning the vulva by normal soap. Urine culture grow more than 105,000 microorganisms which are mixed growth of urine culture. What do you do next? So you have collected by bag, not by cath, and you have washed the vulva with a normal soap and just collected by bag, and examination only temperature and irritability. You don't see any other focus. Urine culture growth more than 105,000 organisms and it is mixed growth. What do you want to do? Repeat culture by bag again. Repeat collection by catheterization. Start treatment with antibiotics. Arrange ultrasound examination. So definitely because it has come mixed growth culture, that means there's some contamination in the urine sample. So you will go for repeat the collection by catheterization.
So when do we start the antibiotics? Patient is presented with fever and irritability.
You will collect with catheter and then you'll start the antibiotic again, Alatul. Catheter, how long it will take? Just in and out.
Okay.
Usually we are doing like that. Whenever we want to give antibiotics, if the urine you want to do, you just give and do by catheter in and out. As soon as you collect the urine, you start antibiotics. 2 months plus general edema since birth. The generalized edema since birth, investigations, reduced albumin, increased cholesterol and triglycerides. It is clear that this is congenital nephrotic syndrome, and the definitive treatment for this is bilateral nephrectomy with protein dialysis. Okay.
Yes. Can explain the question before this?
The question is generalized edema since birth and investigations showing reduced albumin,
Previously.
increased cholesterol and
No,
triglycerides.
after cleaning the vulva by the swab, urine culture 105,000.
Yes.
1 year, healthy present with the high fever, irritable, normal, مش examination with normal except temperature elevate. المهم فبراير وكده واليورين collections بعد ما عملنا كلين للفولفا كان urine culture كان كده thousand microscope mixed gross of urine culture. What do you next? A repeat collection of the catheterizations.
Yeah. Okay, next we will go for the next question. Case of, this is clear, case of hemolytic uremic syndrome, very low hemoglobin, increased BUN and creatinine. That is, kidney function tests are raised and low hemoglobin. A hemolytic uremic syndrome treatment usually dialysis, but if HB below 7, if you have to remember this, if the hemoglobin is below 7, transfer first, then dialysis. So answer will be transfer RBCs, as he mentioned that there is very low hemoglobin. So when the hemoglobin is very low, you will transfer the blood first, then you will go for dialysis. This is what he is telling. I hope it is clear. In hemolytic uremic syndrome, here there is increased BUN and creatinine, but at the same time there is very low hemoglobin. At that time, you will transfer the RBCs and then you will go for dialysis.
Yes.
Okay, patient with nephritic syndrome developed respiratory distress. What might be the cause? No, developed respiratory distress due to induction of albumin. So albumin, as we know, shouldn't be transfused very fast. It has to be given slowly to maintain the osmotic pressure of the blood. Right. If it is infused fast, all these things can happen. But here full question is not given, so I don't think we will understand this. Anyone want to give any comment here?
I think patient with the nephritic syndrome maybe edema and also pleural effusion may develop ascites maybe associated with the decrease the respiratory distress due to indication of low albumins.
Yeah,
low albumin.
Yeah, low
Yes.
albumin can cause pulmonary edema as well.
Pulmonary pleural effusions, ascites, generalized edema.
Yeah.
Sorry, what was the question again? I just joined back.
Patient
okay.
with nephritic syndrome developed respiratory distress due to induction of albumin, but we
It's
have
not induction, it's reduction of albumin. So it's most likely like
pulmonary edema.
Is it edema or embolism?
No, respiratory distress. Respiratory distress is developed.
Maybe may also maybe thrombosis, pulmonary pulmonary
in
embolism.
pulmonary embolism.
Embolism, yes,
Yes.
it's most likely embolism than edema because edema
Maybe
cannot be.
pleural effusion also due to generalized edema. Maybe
Yeah,
pulmonary
exactly.
embolism due to thrombosis.
Yeah.
Yeah.
Can be pulmonary. The differential diagnosis here can be pulmonary embolism, can be pulmonary edema.
It's
So,
more of embolism than edema. If it
okay.
is pleural effusion, yes, because of the generalized edema.
Okay. Treatment of membranoproliferative glomerulonephritis. What is the treatment? For membranoproliferative glomerulonephritis, therapy was induced with pulse methylprednisolone and cyclophosphamide. So you will start, usually I think they will be steroid resistant, but before first they will start with pulse methylprednisolone, then cyclophosphamide, and maintained with cyclophosphamide and every other day prednisolone. Usually what they are doing, to start with, they will give pulse of the methylprednisolone and cyclophosphamide. This is for the remission, to get the remission. Once it is remission is got, then you will go for maintenance with cyclophosphamide and alternate day prednisolone. The guidelines also recommended using angiotensin converting enzyme inhibitor or angiotensin receptor block when proteinuria exceeds 13 mg in 24 hours. So if the proteinuria is 30 mg in 24 hours, they will also ask you to take angiotensin receptor blockers.
Okay, this may be the questions if the patient have membranoproliferative glomerulonephritis with the steroid resistance. What is the treatment?
We read no that one. You will give cyclosporin and tacrolimus in those cases.
What is this? What's this answer? Where in this explanation? They mention cyclosporin with the steroid, or cyclosporin just, or IV cyclosporin and steroid. What?
No. If steroid resistant, they are giving only cyclosporin or tacrolimus.
Cyclosporin just?
Yeah.
Okay.
The guidelines also recommend using angiotensin converting inhibitors or angiotensin receptor blockers when proteinuria exceeds 30 mg in 24 hours for patients in whom treatment with blood pressure lowering drugs and for patients in whom treatment with blood pressure lowering drugs is indicated. Normotensive patients with proteinuria should also be treated with angiotensin inhibition. So the first thing here is whenever there is membranoproliferative glomerulonephritis, you will first give for remission, you will give methylprednisolone and cyclophosphamide. Once remission is done, for maintenance, you will give cyclophosphamide and alternate day prednisolone. And also use of angiotensin converting inhibitors is very important in these patients, especially in patients whose proteinuria is 30 mg in 24 hours and patients in whom treatment with blood pressure lowering drugs is indicated. You have to add them. And even he's telling, even in normotensive patients with proteinuria, you have to consider this. I think this is to prevent hypertension. Because anytime the patients with nephrotic syndrome and nephritic syndrome can go for hypertension, right? Maybe to prevent that. Child 12 years nephrotic syndrome, proteinuria 3+. Biopsy, then steroid. Biopsy, then cyclophosphamide.
Yes, atypical. النفروتك مش كان من أقل من 1 ولا أقل من 2 وأكثر من 10 ولا 12 نقول atypical. عشان كده هنا بعمل البيوبسي then الاسترويد.
Can you again tell me what is the common age for nephrotic syndrome?
I not remember. I say 1 or 2, 10 or 12.
So more than 12 layers is usually atypical, not minimum change disease, not normal.
Yes,
Is
yes.
it 1 to 10 or 1? Is it up to 12? I think it's 1 to 10.
No,
Oh,
this is the reason. This is the reason they are doing biopsy before starting steroid. But if it comes in the age group of minimal change disease, usually you're not doing biopsy. You will directly start steroids and you'll see the response. Maybe you will go for biopsy only for steroid resistant cases, right? But here age is 12 years and he has nephrotic syndrome. So because of that, they want to go for biopsy, then steroid. Case of hemolytic uremic syndrome, treatment, peritoneal dialysis.
If patient of hemolytic uremic syndrome with the renal impairment, yes. With normal hemoglobin.
Hemoglobin?
Yes, لأنه قبل قال لما كان الهيموجلوبين low قال first correct the low hemoglobin by RBC transfusions and after that do dialysis.
So the treatment is peritoneal dialysis here. Case of arthritis diagnosed as HSP, Henoch-Schönlein purpura. Investigation shows raised C3, IgA.
Is there any correlation with Henoch-Schönlein purpura and maybe it is IgA nephropathy then?
Yes.
A case of arthritis diagnosed with hemolytic is this is what Henoch-Schönlein purpura. Investigations show raised C3 and IgA. Raised C3 is not seen in HSP.
No. We don't even check C3 in HSP.
I think so, we'll check, but I not remember well. Associated with low complement, I think that زي ما هو كاتب I think IgA is normal. But I search about it and sent in the group.
Okay, thank you.
IgA vasculitis, formerly called Henoch-Schönlein purpura or HSP, is a disease that causes antibody immunoglobulin A to collect in small blood vessels, which then becomes inflamed and leak blood. Nearly all people with IgA vasculitis developed a red-purple rash. So he is telling that it is the other name for HSP is IgA vasculitis, a disease that causes antibody immunoglobulin A to collect in small blood vessels, which then becomes inflamed and red. So whenever so I don't know if the IgA gets used, it should be less, or there will be more production of IgA maybe. But the level they have not told here, whether it's increased or decreased. The another name they have written is IgA vasculitis. Yes, it is there. Patients with IgA vasculitis and IgA nephropathy have increased serum levels of IgA1. And the vascular immune complexes contain abnormal IgA1, but little or no IgA2. So that means IgA is increased in vasculitis. I will take the screenshots and send in the group, okay?
Okay.
Okay. I will. Next question will go. Nephritic syndrome, we see hypertension, edema plus oliguria. What is the treatment for hypertension in nephritic syndrome? Diuretics and calcium channel blocker. Any comments for this? Because
No, not really.
detailed explanation here. You treat here hypertension with diuretics and calcium channel blockers, or you treat with albumin.
I
No,
think it should be.
sorry, albumin is for the protein
Yeah.
section. So diuretics and calcium channel blockers, because whenever we give albumin, also in between we give the Lasix.
Yeah, pretty right.
Yeah, so nephritic syndrome, hypertension, edema, and oliguria, you can consider diuretics and calcium channel blockers. Okay. Child 12 years old and he has nephrotic syndrome. Again, the same question, 12 years old is repeated here. And on prednisolone 2 mg per kg per day, he developed hypertension plus cataract. What will you do? So cataract can be the side effect of steroids.
Yeah.
And he is more than 12 years, so he will be atypical nephrotic syndrome. So they are considering, instead of they want to start him only on cyclophosphamide.
Yeah, I think since the second line.
Yes, atypical presentation, yes.
Yeah, and then because it's the second line, and steroids, one of the complications is both the hypertension.
No, what you said again, please. As I understand here, he was started on steroid. Maybe he developed hypertension and cataract now. They want to stop steroid and start other drugs. So they are considering cyclophosphamide, right? Is it, or any other?
We'll use also fairly high dose of steroid, 2 milligram per kilogram per day. High. أتوقع as a next line of treatment, because affects the kidney by high blood pressure. I think that.
That's why they are I think cyclophosphamide is the second option they choose. Cyclosporine is only in cases of steroid resistant cases. Cyclosporine and tacrolimus. Here it's given, no? Before we read.
تتذكر لما جبنا سألنا السؤال ده قلنا نستخدم سايكلوفوسفامايد
Yeah. So here, why they changed? As on prednisolone 2 mg per kg per day, you are telling high dose. And maybe after he used this, he developed hypertension and cataract. So now they want to change the medication. Their next option will be cyclophosphamide. This is what I understand.
Yes. زي البقى ديبندنت، لأنه ستيرويد ديبندنت بعد هاي دوز ولسه. أما في الريزيستنت قلت بعمل
If there is resistant, then we would have opted cyclosporine.
Yes.
Okay, now we will not give here IV steroid because already he has taken steroid and he has developed complication. So our option will be here cyclophosphamide.
Yes.
Baby diagnosed with nephrotic syndrome on steroid treatment. Biopsy shows focal sclerotic focal segmental glomerulosclerosis. What to do? So again, this comes under atypical, okay? A baby diagnosed with nephrotic syndrome on steroids and biopsy shows focal segmental glomerulosclerosis. What to do? increase the steroid dose, nothing, add cyclophosphamide. We read this before. When there is steroid dependent FSGS, the option is steroid plus cyclophosphamide. I will go back to that slide so that we will remember this, because the questions are repeating on that. This one. Child with the FSGS nephrotic syndrome, no remission after 8 weeks of steroid. What to give? Oral steroids plus cyclophosphamide. But here he is very clear. If steroid dependent and frequently relapsed, you will give cyclophosphamide and alternate day steroid. If steroid resistant, you will go for cyclosporin. So FSGS, usually there is a chance of relapse. Even if it is steroid dependent, it can be frequently relapsed because it is FSGS type of this nephrotic syndrome. So you will add cyclophosphamide to that. So it's not increase the dose.